Medurstand Understanding Medicine.
I am Professor Aziz from Medurstand-Understanding Medicine. This is part 2 of the lectures on erectile dysfunction. And if you haven't watched my earlier video, I think I would suggest that you watch that one first, because it is very important to understand the normal physiology of erection. How does normal person have erection? And only then you will be able to understand this erectile dysfunction and the treatment. So since I have covered the normal physiology, this time I'm going to talk about the assessment and the treatment. Both videos make one module. So the prevalence of erectile dysfunction, according to this Massachusetts male aging study, and the men of 40 to 70 years age, and there is incidence of partial erectile dysfunction up to 52%. If you remember the definition, it is the inability to have persistent and sustained erection sufficient to have a satisfactory intercourse. So this is a relative thing. Many people, they have this partial, they are able to perform sex intercourse, but it is not to their satisfaction. Or there could be complete loss of erectile function. That means one is not able to have intercourse at all. So the incidence is from 52%, which is half of the population, 40 to 70 in men, and 10 to 25% would have complete loss of erection. So that would of course be very, very distressing and problematic. What are the risk factors? There are some people who are more prone to develop erectile dysfunction than others. First of all, diabetes. Diabetes has got multiple components, not only hyperglycemia, it is characterized by premature atherosclerosis, also autonomic nervous system problems. So I think diabetes can cause erectile dysfunction through multiple mechanisms, if particularly somebody is not controlled and HbA1c is very high. Then cardiovascular disease. I think all cardiovascular diseases, particularly ischemic heart disease and heart failure. You know, the erection is linked to pumping of blood into the penis. So if somebody has got a failing heart, he might not have this function intact. Obesity. Obesity is often associated with the erectile dysfunction because most men with obesity, their testosterone level is actually reduced. And smoking, especially if it is chain smoking, that can cause erectile dysfunction, or at least can contribute to erectile dysfunction. Depression, I think, is one of the major causes of depression, major causes of erectile dysfunction. And in fact, if we are unable to find any cause, we usually attribute it to depression, or we say it is psychological. But depression, especially the morbid depression, is definitely associated with erectile dysfunction. And in fact, not only depression, many antidepressant drugs are also, they contribute to erectile dysfunction. Then aging, you know, although there is traditional thinking that men never age from sexual point of view, but actually the reality is that with time, men's sexual function, they decline. So at later age, 80, around 80, 90, I think most people would have their erection affected. So what is the etiology of the one? We discussed about the risk factors, and these are etiologies in specific terms, mostly vascular. In vascular, I think any premature or accelerated atherosclerosis in diabetes or people with hyperlipidemia, or the endothelial dysfunction. Then it could be neurological. Diabetic neuropathy is one example, but any injury to spinal cord. It could be traumatic, it may be a result of surgery, it may be a result of some radiation. So any significant trauma to the spinal cord could cause erectile dysfunction. Then hormonal, because erection is driven by certain hormones. Hypogonadism, which could be primary or secondary. If your testosterone level is very low, then there is a possibility that you might develop erectile dysfunction. Further on, we have psychogenic causes. Anxiety and depression both can cause erectile dysfunction. Drug-induced, I think, is very common cause. Many antihypertensive drugs, they can cause erectile dysfunction. Some SSRIs, the selective serotonin reuptake inhibitors, which are fairly commonly used these days for depression, they can cause erectile dysfunction. In fact, this is a short list. There are many drugs. There are many drugs which can contribute at least to erectile dysfunction. Then idiopathic, even we have detailed history, there is no psychosomatic cause, there is no depression, patient doesn't have diabetes, patient doesn't have any evidence of atherosclerosis, but still patient has this erectile dysfunction, we label it as idiopathic. So how do we assess? I think first of all is history. You must encourage the patient to give every relevant detail. In our culture, this is usually not done. And in fact, many people would have the issue, they would not even mention to the doctor. And I think if you have somebody who has a risk factor for erectile dysfunction, as a physician, you should encourage the discussion. And typically, a couple is interviewed together, but in our culture, I've seen that when man is consulting and there's a woman also, I mean his wife is also there, at the end of consultation for diabetes or hypertension, then that patient would request the wife to go out, and immediately I figure out that this patient is now going to talk about his erectile dysfunction. So I think a thorough history, how often this happens, how long this has been happening, is it with one partner, is this one time or multiple times, and is it complete loss of erection or partial, is it intermittent? All these things should be discussed. What medication patient is taking, I think all this is, and you should go through the chart that will give you important clues to the diagnosis. Then we have to decide, is it primary or secondary? Of course, as the word would say, primary means that somebody never got the erection, and secondary means his erectile function were okay, but only recently he lost his erectile function. The etiology may be different, the treatment may be different. And then more than one time, in fact, the very definition of erectile dysfunction requires that it has to be more than one time and with more than more than one partners. And you should also ask if the morning erection is intact. This is a non-sexual stimulation of penis. Many men, especially in the young age, they notice that there is erection in the morning when they wake up. If somebody has lost this erection also, that would suggest that there is probably an organic cause like spinal cord injury or autonomic neuropathy. If somebody has intact morning erections but he is unable to perform intercourse, that might suggest this is psychological cause. Then medication, very important. I think you must go through all the medication patient is taking. You might find some which are responsible for erectile dysfunction, and then you decide if that medicine is necessary or patient can be taken off from that medicine. Of course, there could be some medicine which may be absolutely necessary, so then you have to give an alternate. If you are not sure if the particular medicine or the medicines or may be responsible for erectile dysfunction, it is best to consult a reference book or the internet these days. So I think nobody can be 100% sure. Even in front of patient, you just check the internet or some other reference and see if that drug may be responsible for erectile dysfunction. Then local examination must be performed. You must make sure that the penis is normal in anatomy and normal in size. Testicles are also normal in size. Some people, they may have very small testicle. That of course means they are atrophic, and that may be responsible for hypogonadism. Then cardiovascular system examination, examination of pulse, blood pressure, precordium, and of course everything related to cardiovascular system should be examined. And then CNS, central nervous system, and peripheral nervous system examination is required. I cannot go into the detail, but briefly you would examine the cranial nerves and you would also examine the peripheral nerves, like you would check reflexes and the sensation. Routine labs, I think all these patients who come with erectile dysfunction, it would be a good idea to have the routine labs like their CBC, their blood sugar, their cholesterol, uric acid, and kidney function, liver function. They may give you clue, or you might find another treatable condition. So I think routine labs should be done in all patients, but then relevant test or the imaging. Because these tests may be expensive and may not be available everywhere, so you would do these tests only when needed. For example, if you have identified a drug which may be responsible, then you of course do not need imaging tests also. So this is how we do the assessment. I think I would emphasize on local examination and a thorough history. These are two most important things, and the medication patient is taking. So what are the relevant labs? Not needed in all, but you would in a specific patient you will find which lab is relevant. For example, testosterone level. You could have total testosterone level or the free testosterone level, but it should always be done in the morning because testosterone level has a diurnal variation. The lowest level is in the morning, so I think you want to check it at that time and you don't want to miss the diagnosis. So I think, and typically it should be done more than once. Along with that, we also determine sex hormone binding globulin. This is something which binds testosterone. If you're measuring total testosterone, the total testosterone level may be okay, but most of it may be bound to sex hormone binding globulin. This testosterone is measured in the test, but it is not functional. So that could give you the clue that although the testosterone level is normal, but patient actually has to have functional deficiency of testosterone because most of it is bound to sex hormone binding globulin. And this particularly occurs in elderly people. As you grow old, your sex hormone binding globulin level goes up. And then follicle stimulating hormone and this LH, these two enzymes are produced by pituitary, follicle stimulating hormone and luteinizing hormones. They work in harmony, and in harmony they produce testosterone and spermatogenesis, and they may be contributing to erectile dysfunction. So I think you need to test them. Prolactin level, extremely important. Normally prolactin is inhibitory to the sexual function, and the commonest reason of having high prolactin, believe you me, is not a tumor, is not a prolactinoma. The commonest cause is some antidepressant or antipsychotic drug. So if prolactin level is high, don't jump to the diagnosis of prolactinoma. Of course, if patient is not taking any drug which could be responsible, then you might have to go for pituitary MRI, brain MRI to find out prolactinoma. Sometimes total body imaging, because sometimes prolactinomas could be ectopic. Then ultrasound of penis, because with Doppler and ultrasound of penis, one can determine the normal anatomy of the structure. Sometimes there could be, everything is normal, but there is leakage from the trabeculae. So the blood doesn't build up in the trabeculae, and that may be responsible. And these patients might require some kind of surgical treatment. And then pelvic MRI, malignancies in the pelvis like prostate cancer, if it is advanced, that could cause erectile dysfunction. And then spinal cord MRI, especially if there is a history or if there are some neurological signs suggesting of spinal cord injury, paraplegia, or loss of sensation in the penile area, the saddle anesthesia, then I think you need to do the spinal MRI also. So one or more of these tests may be required in the given individual. In some, no test may be needed, but in some, you may need some or other of these tests. Now let's talk about the treatment of erectile dysfunction. First of all, there are some general measures. Patients should know the normal health principles. For example, patients should be taking normal, healthy, balanced nutrition, vitamins, supplements, good balanced nutrition, and patients should not be grossly overworked. Patients should have some rest also. I think only then one can have sexual activity. Then psychosocial therapy is one tool. Then drug therapy is another one. Intracavernosal injection. This is very, very effective, but many men, they are reluctant to use because nobody wants to inject a drug into the penis because they think this is not the right way of getting erection. And of course, there sometimes some people are having phobia about the needle also. Transurethral alpostadil, this is a prostaglandin which can be given through the urethra. It is effective, but not as effective as intracavernosal injection. Intracavernosal injection could be piperine or alprostadil. So these are injections which are given. Then vacuum devices. Vacuum devices is something which you put on the penis, then vacuum is generated and then leads to erection. Then a band is applied to the root of the penis and the erection is maintained and one performs sex. Then surgical treatments. And of course, I cannot discuss all of them. I do not actually know the details of everything, but I'm going to discuss this drug therapy. Drug therapy, because that is what is available. Sildenafil, famously known as Viagra, and tadalafil, again Cialis, famous name, the vardenafil, Levitra, and avanafil, Citendra. All these drugs, they are phosphodiesterase inhibitors, but they have different pharmacokinetics and pharmacodynamics. Just comparing these two, I think I'll compare in one of the slides. Some are short acting, others are long acting. Both have their advantages and disadvantages, but all they work through the same mechanism. I explained to you how phosphodiesterase 5 is responsible for maintaining erection, and now I will explain how the inhibitors are responsible to maintain the erection. So mechanism of erection, role of sildenafil, and this I think I showed you in the last video also. There is production of nitric oxide through the autonomic nervous system through using the non-adrenergic, non-cholinergic pathways. Nitric oxide leads to the stimulation of guanylate cyclase, and which converts GTP into cyclic GMP. Cyclic GMP produces smooth muscle relaxation, dilatation of trabeculae, dilatation of arterioles, and that leads to erection. And these drugs, they work here. The phosphodiesterase inhibitors, they work here, and particularly phosphodiesterase 5. Now you must appreciate that multiple phosphodiesterases, all of them, they have the ability to destroy cyclic GMP, but phosphodiesterase 5 is particularly responsible. And the drugs we have these days, sildenafil, tadalafil, they work on the phosphodiesterase 5 only. So about sildenafil, the profile, the first of its class, FDA approved in 1998, and the preparations available at least in Pakistan, 25 milligram, 50 milligram, and 100 milligram. I think in all patients you should give a trial of 25 milligram at least 2 or 3 times. If that doesn't work, then 50 milligram, and if that doesn't work, then 100 milligram. You cannot go beyond 100 milligram. If you are not responded to 100 milligram, that means your problem is slightly different, maybe some other issue. Then indications are sildenafil is indicated in the treatment of erectile dysfunction and also pulmonary hypertension. Of course, I will cover pulmonary hypertension in a separate lecture. Mode of action, phosphodiesterase inhibitor, and onset of action is 30 to 60 minutes. Now this is important because many men, they take it only when needed. So I think typically on a weekend, if the sexual activity is planned, one can take it 30 to 60 minutes before the planned sexual activity. I suggest 60 minutes is more appropriate, but not longer than 2 hours, because then the affection is diminished. At 30 minutes, you may have some effect, but not full effect. So I think to have the full benefit, 60 minutes after taking medication, and medication is best taken empty stomach, but if you take it after meal, even then it will work, but of course the effect will be slightly diminished. Duration of action is about 4 or 5 hours, that means one night or one day, and it is excreted through liver. So if somebody has got advanced liver disease, that may be a contraindication, but having a little bit of fatty change, that should not bother you. So I think this is, but it doesn't interact with other drugs which are excreted through the liver. Side effects, there are many, like it can cause some heaviness of the head, headache. There may be some nasal stiffness, some flushing, nausea. These are due to vasodilatation. Although vasodilatation is mostly specific to the penile arterioles, but there is some systemic vasodilatation also. There may be some nausea, some dizziness because of drop in blood pressure. There's some visual problem, very rare, but some patients, they have this visual. Luckily, that is usually temporary. And priapism, this priapism is potentially serious side effect. Priapism is if somebody gets erection that doesn't go like more than 3 hours. This might actually require surgical intervention. Contraindication, there's some absolute contraindication, co-administration with nitrates. If you recall the mechanism of action, this drug also stimulates production of nitric oxide. So if somebody is already taking nitrates and take sildenafil, there may be too much vasodilatation that could lead to precipitous blood pressure drop and syncope. So you never prescribe with nitrates. If somebody is taking nitrates, he should consult with his cardiologist. If he can take a day off nitrates, and you can take, I think, 48 days off nitrate and then take sildenafil, and after 24 hours you can restart nitrates. So I think it's very, very subjective. I believe somebody having heart disease and taking nitrates, probably sexual intercourse would not be his priority. Hypersensitivity mechanism, of course, one can be allergic to any drug. That was the absolute contraindication. And there's some relative contraindication, co-administration with non-selective alpha blockers, the old-fashioned drugs which are given for prostate. But the newer ones, the newer alpha blockers, they are very, very selective. With the new alpha blockers, I think you can give. In fact, sildenafil is also indicated for, not the sildenafil, the tadalafil is also indicated for prostatic hypertrophy, so both drugs are co-administered as a policy. Comparing sildenafil and tadalafil, I'm comparing these two because these two are available in Pakistan. So sildenafil onset of action predictable and duration of action short. In tadalafil, onset of action is slightly unpredictable and duration of action is much longer. So this works for only a few hours. This works for 36 hours. Many people would view it as a good effect. It may be a good effect because with one pill you can have 2-3 rounds of intercourse over 2 days, but it could be a problem also. If somebody has a side effect, then it could be a problem. I just recently recalled somebody complaining of this, that after taking this medicine, he is getting inappropriate erection throughout the work, and it will actually affect the workplace. So best time to take 1 hour before planned activity. That is 30 minutes to 4 hours, but I think best is 1 hour. Tadalafil, best time to take 2 hours before planned activity, 30 minutes to 4 hours. I think again both can be taken as per required. Approved indication in sildenafil, we have 2 indications, erectile dysfunction and pulmonary hypertension. For pulmonary hypertension, the dosage is different, the name is different, the brand is different. So this talk is primarily focused on erectile dysfunction, but there are many off-label uses. We know it is a vasodilator. It can be, people use it in various conditions where vasodilation is required. I'm not going to mention those because then that would be like recommendation. I'm not recommending it anywhere, but many physicians, they use it whenever vasodilation is needed. A tadalafil approved indication, erectile dysfunction, and pulmonary hypertension, and also BPH. For BPH, you are typically given 5 milligram every day. So this is an extremely useful function. If somebody has erectile dysfunction plus prostatic hypertrophy, one pill will solve both the problem and the person will be very happy. Pharmacokinetics: sildenafil is rapidly absorbed after oral administration. Maximum plasma concentration is achieved around 60 minutes. Duration of action, and action is bold because it is a special action, 4 hours, and excreted by liver. Percentage of patient responding to sildenafil, and this depends on the age. This is a trial which has shown that with placebo 24%, with 25 milligram Viagra 63% chances of having erection, and with the 50 milligram there's 74% chances, and with 100 milligram there are 82%. So even with 100 milligram there are not 100% chances. Because the erection is very complex mechanism, somebody may be having some issue which the drug doesn't work. Like for example, if there is leakage of trabecular system, then Viagra or any other drug would not work. So ladies and gentlemen, coming to the summary of this, is the summary of two presentations. Erectile dysfunction is common and under discussed, underdiagnosed and undertreated problem. Please, if you have a patient, encourage the discussion and provide appropriate help. It has a major impact on men's sexual, psychosexual, psychosocial and mental health. Many people, they are actually shattered after having erectile dysfunction. There is wrong perception among people that sildenafil is a very dangerous drug. And I know many people, when I prescribe them sildenafil, their first reaction is, no, I can't take this because I have this problem. I don't want to have blood pressure rising or blood pressure dropping. So I think you need to set their expectation right. You should explain to the patient what to expect. Of course, like any medicine, it can have side effects, but it is not unusually toxic. It's just like any medicine. Identify appropriate patient. Try sildenafil first time 25 milligram, I think 2-3 times. If no work, 50 milligram. If that doesn't work, then 100 milligram. But please don't go beyond 100 milligram and don't take more than once a day because that could cause problem. Never co-administer with the nitrates. So with that, I'd like to thank you for patient listening. This has been Professor Aziz Rahman from Medurstand-Understanding Medicine. I will again remind you that there is another video on the same topic explaining the physiology and pathophysiology of erectile dysfunction. I would suggest that you watch that video also. Thank you very much for your patient listening. Aziz Rahman from Medurstand-Understanding Medicine.